Okay, we're going to get started. Our first presenter is Dr. Adam Walsh. Dr. Walsh currently serves as the Director of Research and Program Evaluation and as a subject matter expert for the Department of Defense Suicide Prevention Office. Dr. Walsh has 15 years of experience in studying and developing suicide prevention interventions.
Well, thank you. Ladies and gentlemen, I greatly appreciate it. Congressman Mullin, it's an honor and privilege to be here. Suicide is not always the easiest topic to discuss, but every time we do, we go around and we speak to many different audiences. We just the fact that lots of people are here and we're able to talk about suicide, especially among men, we move one small step closer to decreasing some of the stigma that does surround suicide and mental health, especially around men. We know there's a lot of stigma, and it's very difficult to talk about this issue. But every time we do talk about it, we talk about how complex it is. We talk about the different ways to prevent suicide. It certainly helps because we need all of you. We need the entire nation to help us with preventing suicide because it's a very difficult outcome to prevent, and to bring down our rate of suicide will take all of us. So thank you very much for being here and having me here. Thank you. So before I talk to you about some of the active duty suicide prevention numbers, I want to talk a little bit about our approach in the DoD. We take a holistic public health approach to suicide prevention. Certainly mental health, having access to mental health services, dealing with mental disorders is important. However, we know with many years of research around the world that it's much more complicated than mental health. There's a lot of different factors, environmental factors, situational factors that we must address. And so that's why in the DoD we take a public health approach. And we have a strategy that includes about 60 goals, or about 60 objectives and 14 goals. It's the defense strategy to prevent suicide, very much taken from the national strategy to prevent suicide. So these areas span from accessing, making sure that people do have access to good quality mental health care, but it also places equal importance on safe messaging, making sure that we talk about suicide in a responsible way, that we have communities engaged in suicide prevention, that people understand what are some of the factors that increase risk for suicide, and that we know the protective factors as well, that we have peer support, and that we have lots of community people understanding how we can support individuals who may be at risk for suicide. We also know that alcohol and drugs are important in having policies around those issues. And then also access to lethal means of suicide. We know it's important to store medicines safely. We know that it's important to have barriers on bridges. And we also know that it's really important to safely store firearms, because suicide can many times be an impulsive act. And so it's very important to keep environments safe around individuals. So what you'll see here is active duty service member suicide rates. And what you'll see is from 2010 through about 2016 is that, and a little bit before that, is that the rate has stayed. I'm going to be talking from a statistically, kind of a statistic standpoint, in terms of the rate has stayed kind of stable. So every suicide is a tragedy. We don't want any suicides, but in terms of understanding what is the rate of suicide doing in the active component, we know that for the last 7 years it stayed about the same. And that's not acceptable to us. We want it to go down. And so we are doing whatever we can to bring that rate down. Okay, in terms of males, we know that males are approximately about 4 times more likely to die by suicide than females. And the reason for that in many different research studies is that men usually use more lethal means of suicide. Men usually use a firearm to die by suicide. And using a firearm in suicide, it's about 93% fatal. So compared to females, many females use medications, and that's not as fatal. So one of the main reasons why the suicide rate may be higher for men is because of the method that men use. Also, the military has a higher percentage of males, and so we, in the military, we have about 93% of our suicides are men. And one of the things I wanted to point out, what I said earlier, is that mental health is important, but we also know in our numbers, in our surveillance numbers, we know that over half of the individuals that die by suicide do not have a diagnosed mental illness. And that's very similar to the CDC for the nation too, is that a little over half of those individuals who died by suicide do not have a mental illness. So this points out how complex it is. And also, this is important because what we want people to understand is it's not just the individuals that you think are chronically depressed or mentally ill that we need to be reaching out to or looking for. As I said before, suicide can many times be impulsive. So we need to reach out to individuals in the military. As you know, people who serve in the military have to be pretty high functioning and are functioning at a pretty high level. So many of these individuals, they may have a lot of situational stressors. Relationship problems are one of the top stressors in the military, along with financial issues. And so some of these stressors we need to pay attention to. So maybe this isn't the individual who is always isolating himself or looking sad or depressed. This person might be situationally going through some very difficult times. We want to reach out to that person. But we need to open our eyes and open our minds that this person may not be that stereotypical person who we think is depressed that may be at risk for suicide. Okay, so help seeking. This is one of the things that is very important in our department and something that we've known for a while and we need to continue to address. We know that men have a hard time asking for help when they're having a problem. And what we know in our recent data and the data that we've collected is that more than 2 in 5 service members would not seek help if they thought of suicide. So that's troubling. And we know why. They've been telling us why for a while. And that's because they're concerned about the perception of being broken. Also, they're worried about their career and jeopardizing their career, and desire to fix one's own problems. And we've been seeing the same data and these same reasons for a while now. And many people, many service members, they don't want to seek a clinical provider. They want a peer or they want a friend. They would like those individuals to help them. And that may be due to just their comfort, but it also may be due to their concern about their career. And we know that especially officers, male officers, senior enlisted, they're very concerned about their career and seeking help. In fact, in a survey in 2016, about 79% of the Air Force officers said that they would not seek help because they were really worried about their career. And so this stigma, this concern is real. And so this is one of the areas that we're really focusing on is how do we increase help seeking, and what are the other options? We know there's clinical treatment, but service members are saying they want other options. So we're trying to work with the DoD and other agencies to make sure we provide multiple options for help seeking. So here again, you can see the top reasons for why service members would not seek clinical care. So one of the questions that we asked on the status of the force survey, which is a DoD-wide survey, is we know that one of the risk factors or triggers for suicide is feeling trapped or stuck. And so one of the questions we asked is, if you felt trapped or stuck, what would you do? And the majority of service members said they would deal with it on their own, 71%. And then also about 50% said they would ask someone, and then self-help or avoid the situation or ignore the situation. And so a lot of service members, they want to fix it on their own. Right. So what are we doing to address some of the barriers to help seeking in the military? One of the things that we have found in some of our research is that service members are more likely to see a chaplain if they're going through a difficult time. One of the reasons is because a chaplain is completely confidential. And if you look at the data, many service members are, apprehensive about seeking clinical treatment because of the potential ramifications for their career. So they will seek out a chaplain. So what we have done in the department is we've invested some training and resources in training up chaplains in suicide prevention, recognizing the risk factors for suicide, and then using some evidence-based approaches to helping that individual manage that person's thoughts and behaviors of suicide. And so far, our data looks pretty good. We are able to train chaplains on some cognitive behavioral strategies. And these are some of the same strategies that somebody would receive if they were going to go to clinical treatment and receive cognitive behavioral therapy. Another thing is training chaplains just in evidence-based counseling and how to do reflective listening and how to identify the risk factors for suicide. Another thing that we're working on is a barrier reduction intervention, where we're going to be training service members how to ask for help. We know that they will need help at some point in their life, so let's go ahead and practice what you would do to get ready for a situation where you may need help. Another area we've known for a while is the data shows very clearly they want their own skills. They want to be able to solve their own problems. So in the Navy right now, we're doing a trial of an intervention where we're training young service members, 17, 18, 19-year-olds, how to learn how to do problem solving, emotion regulation, some of these core skills that we know protect against suicide. Also social problem solving, good interpersonal skills. We also know that that's a good protective factor, so that's also one of the new projects that we have going on. So I greatly appreciate it. I see the 1 minute, so thank you very much for your time.